Hello, everybody. Thank you for joining us. This is one in our series of discussions about aspects associated with COVID-19. And one of the things we realized in our field of healthcare management, healthcare economics, healthcare policy, and population health is, and one of the things that makes our field so unique, is that you cannot manage and deal with the economics of this field without also dealing with the ethics associated with this field. You're dealing with human life. And so as a result, things become far more complex in terms of how we evaluate and assess issues. So we're extremely pleased today to have with us one of our major experts in the area of bioethics, a person who has truly a global reputation, and I say that with all sincerity. What I'd like to do is have our people introduce themselves to us who will be involved with this, and again, focus on some questioning of Dr. Goodman. I'm Dr. Steve Allman. I chair the Department of Health Management and Policy at the University of Miami's Herbert Business School, and I also am director of our Center for Health Management and Policy. I'm a healthcare economist by background. Let me introduce Dr. French.
Okay. Thank you, Steve. So I'm Michael French, and I'm a professor in health management and policy. And I teach health economics, health policy. I teach some business and society issues as well. And I'm very excited to be part of this webinar.
And Dr. Dean, please.
I am Dr. Emma Dean. I'm an assistant professor in the Health Management and Policy Department. I teach population health for undergrads and grad students. Also a health economist by training and interested in the pharmaceutical industry. So very interested to hear more about what Dr. Goodman has to say.
And then our guest for this webinar is Dr. Ken Goodman. Dr. Goodman, please introduce yourself and tell us a little bit about yourself.
Well, thank you very much. The privilege that I enjoyed this decade is directing the University of Miami's Institute for Bioethics and Health Policy. I'm a philosopher by training, but my appointments from the Departments of Medicine, Philosophy, and some others. My teaching involves medical students, science students, and undergraduates. I found myself lately to be trying to help our institutions. I get to chair the Ethics Committee for UHealth and the Adult Ethics Committee for the Jackson Health System, trying precisely to manage the challenges that we're facing now in the coronavirus emergency.
Thank you, Dr. Goodman. And again, what makes this period unique, medical ethics is always a part of what we work with in the area of healthcare economics, management, and policy. Again, my field as well. But what makes this time so unique is the COVID-19, an aspect of healthcare that we really haven't seen since 1919, period of the last major pandemic, the Spanish flu. So there are all kinds of issues that come up. What we'd like to do is start with if you will, a macro approach to look at some of the policy issues, and then sort of delve down even into some of the micro issues that come up in a healthcare facility in and of itself, and the individuals who work on that. But I want to start with our questioning from Dr. French in terms of some of these macro issues. Michael, please.
Okay, thanks, Steve. So I'm going to start by just reminding everyone that as economists, we're always dealing with the efficient allocation of scarce resources. I always remind students, and my colleagues and I adhere to this in a lot of our research, that resources are scarce, and so we have to make choices every day about how to allocate those scarce resources. But that is particularly poignant in today's delivery of scarce resources to deal with the COVID-19 pandemic. So my question for Dr. Goodman is the following. So when medical care resources are scarce, as they are now, and I'm talking about things like PPEs and ventilators and the healthcare workforce in general, as health economists, we often advise to allocate these resources based upon value rather than equity per se. For example, equity would say that first person in, first person treated, but that isn't necessarily the best use of those resources, and that might not produce the best value. So I'm interested to hear from Dr. Goodman, how would such allocation rules that rely on efficiency and highest value align with or collide with the principles of a bioethics researcher.
Thank you. I might urge you to add testing to the list of scarce resources.
Yes.
And allow me to ask, by way of answering, how is it in the United States of America, with the lives that are on the line, are we having this scarce resource problem? In other words, generally speaking, there's always not going to be enough of what you want. But given the crisis that we face, and how to some of us who are, well, to people who are trying to think clearly about what we want in civil society at the seam between ethics, economics, and public policy, you could argue that we probably should have had enough PPE by now, and we probably should have had enough ventilators by now. And in terms of the economic questions and reopening society, why, after all the water under this bridge, do we not have enough tests? But your question is a very important one, because it goes to the difference between the kind of approaches that we usually try and have in healthcare, and those which matter more for population health or matter more in an emergency. Normally, matters of equity are sort of either assumed or not reckoned to be that intense. In fact, those of us in our community who don't have access said it's all along. And so one of the things we're discovering now is how the inequities in our system are becoming lens during the emergency. But if you're looking at the beginning with the idea of value, that's an important consideration. If you're in the business world, it produces a return on investment. It justifies the investment. It makes it clear that when we try and in various markets to try and identify the best way to magnify different things. But if it turns out that it's something that's life-saving, then all the values end up getting flipped. I mean, what I learned from Professor Ullman many years ago is that usual rules of supply and demand and all the cost-benefit curves are reversed when it comes to healthcare. Normally, if you want to sell more of something, you lower the price. It turns out that the demand in healthcare is going to exist no matter what the price is, and you might have an effect of pricing people out of a market that they really want to participate in. The value that comes to the fore in public health, in population health, and in emergency is a utilitarian value. It's what can do the greatest good for the greatest number. And so considerations about value are value to whom, and there are a lot more stakeholders when it comes to that. But assuming everybody now is a stakeholder, then considerations of greatest good for the greatest number are the ones that tend to predominate. It's how, if you don't have enough ventilators, I might not get one. And so value ends up taking a back seat to questions of what would be a fair distribution of those resources. As a result, first come, first serve doesn't work very well, because if I'm really sick and going to die anyway, giving me the ventilator is a waste of the ventilator, that sort of thing.
Mm-hmm. Very good, very interesting, and a similar perspective, but some differences as well. Just to make a comment about your first question, which was, how can we find ourselves in this position? I get asked that question as well quite a bit from students and from friends and other colleagues. And my initial response is that preparation is expensive. We could have prepared for this, but that would mean a lot of resources in stockpile for long periods of time, perhaps before they were used. But always we can look back and say, why were we not prepared? And whether it's for a pandemic or for a natural disaster or for an active shooter who is leading to casualties as well. So,
well, but that answers your own question. Interesting. The way to prepare for active shooters is to not put a bunch of cops and paramedics in open places. It's to reduce access to guns. Mm-hmm. And the way to prepare for having tested a pandemic is not to have a lot of stuff in the warehouse. It's to have a system that's nimble enough to respond to an emergency. My favorite cartoon, there's a great cartoon of these two guys walking down the street, and it's snowing and sleeting and the wind is blowing and the rain's going sideways. And then there's a newspaper, it says terrible weather. And one turns to the other and says, every year we get this unpredictable weather. Mm-hmm. Sooner or later, we need to be, the idea that your point is a very important one, but there are more nimble ways you could argue that we could try and prevent shortages in times of emergency.
Absolutely, absolutely. And it's not like we didn't know that this was a possibility until February or January of this year. We certainly had plenty of warnings. So let me take it in a slightly different direction, also related to the possible advantages and disadvantages of different strategies. So one of the hotly debated issues right now is, what is the appropriate response? And we're already starting to see some pressure about relaxing social distancing policies and restrictions. But let's look at the two extremes. So one extreme would be a total lockdown of society, which in the US and other countries, we're pretty close to that. Another extreme is an approach that's being taken by Sweden right now. And as last I looked, they were still following this, which is continue with business as usual, and let's allow people to develop immunity, recognizing that this is going to lead to more infection and more deaths. And that's okay, because we're still going to keep the economy running, and we will just make sure that we have enough resources to treat the people that do get sick. So how would you view those two extremes, and perhaps settle on something that is more in the middle? So I'd like to hear your perspective on those.
Well, one of the things about Sweden, it's a very interesting question. In some sense, we've had the good people of Sweden volunteer to do that for us, to see how well it works out. Imagine we approach this as a scientific problem and got different countries to adopt different ways of trying to manage it, and see who ends up best in the end. The problem is a lot of confounders and that sort of thing. It also helps to have a reasonably homogenous society, as the Swedes do. Every effort we've made to try and manage this has been met by the discovery of terrible failures of our system based on race, based on socioeconomic status. The disability community is grievously concerned about some of the rationing and triage proposals that we're trying to advance. And so I don't think an emergency is a good time to try and fix your society. It's a good time to learn about what's wrong with your society and take steps next time so you do not have such disparities. But in fact, there's a kind of, Michael, your question goes to how much can we build evidence in to the decision procedure as we're gradually changing things and going back to normal. If we go back too quickly and there's a spike and a lot more people die, then we'll say, well, we wish we'd gone more slowly. I suppose some people would say that's worse than having people inconvenienced and damaging the economy, mind you, a little bit longer, in the interests of saying, well, we could have done it earlier, but we didn't know better, and we've paid for that by saving some lives. I think a lot of people might say that that's actually a price we probably ought to be prepared to pay. The costs of this are daunting, and this is our first rodeo. I mean, Steve's point that we haven't seen anything like this in a century is when there was no social media, we weren't even aware of how different elements of our community were being systematically excluded. And by the way, in 1918, there was not a whole lot to do if you got sick. They didn't have ventilators back then, and so as we're trying to come to terms with that nexus, I want to see something that builds evidence into a cycle very quickly. Trusted evidence with trusted brokers analyzing it, advising people in government. That's something we actually, I mean, that alone would be novel. Imagine the President of the United States actually having and taking advice from trusted scientists. I'm joking, of course. That's, everyone would agree, it's not a political observation, that's an anthropological one. In modern industrial society, we need to rely on people who know how to collect, analyze, and share evidence, and that should drive policy, that and nothing else. So I think if we do what you've suggested, then we begin opening things up, learning from the Swedes as much as we can, despite the fact we're not sure how much of a good model they are, then we'll be able to see our way clear, I think, to opening as quickly as possible, where as quickly as possible entails it will also be as safe as possible.
Mm-hmm. That makes a lot of sense. One of the interesting and somewhat difficult and painful aspects of making policies and coming up with hard choices and making those decisions right now is this is a classic case of decision making under uncertainty, in the sense that we know about the people that are sick and those that are requiring healthcare and those that are not making it. But what we don't know right now is the fallout from the policy of shutting down the economy, which is undoubtedly going to lead to a lot of suffering and a lot of financial distress. But there's also benefits associated with that in terms of improved climate. We have reduction in traffic fatalities. So this is a case where we just don't have good information about what the alternatives have in terms of the benefits and the cost of those various options. So what I'd like to do now is turn it over to Dr. Dean, who has a question about some of the pharmaceutical aspects of this pandemic.
If I might just respond briefly,
Mm-hmm.
I don't know about you, in South Florida, I've noticed that there are more birds than I've seen in years.
Mm-hmm.
But you're right, there are fewer traffic accidents. Our colleagues in emergency departments and hospitals are reporting a dramatic decrease in violent crime. Gunshots, stabbings, all that sort of thing are way down. If the government were more nimble in providing financial support to people who are enduring the shutdown, then some of those other personal costs would have been mitigated a little sooner than they have been. I just mentioned that's why we turn to health economists to help guide us in thinking about how to factor those kinds of considerations in.
So it may be curious to see if indeed people become more distressed, more frustrated, not able to have access to money. Will crime start increasing again as people become more desperate to be able to feed their families, pay their rent, whatever? I'm sorry, Dr. Dean, please. One of the areas is vaccinations, which is one of the things we're sort of hoping for sooner rather than later, but there are definitely some ethical implications associated with that. And this is Dr. Dean's specialty area. So Dr. Dean, please.
Sure. I have a question. It's actually related to Dr. French's first question. So when a safe and effective vaccine for COVID-19 is eventually developed, and hopefully that's sooner rather than later, and approved by the FDA, we know from supply chain issues with vaccines kind of across other areas that supplies will initially be low. And so not everyone in the US will be able to get the vaccine immediately. So again, health economists would assign placements in the queue to get this vaccine based on value, such that those who could benefit the most, such as elderly patients, those with chronic conditions, would be the first, and low value individuals, such as the young and healthy, would be vaccinated later. So how would a bioethicist assign vaccine ordering when we have a limited supply, especially at the beginning there? Because there's also, of course, the trade-off of the young and healthy also are more likely to be in the workforce and need to get back to work quicker.
One of the things that we don't have a very good, we have a rough and ready sense of what it means to be vulnerable, but it's very difficult to try and make it so that it's measurable in ways that will go into a decision procedure the sort you described. I think I may have shared earlier with your colleagues, my favorite new philosopher is Yogi Berra, who famously said that it's really hard to make predictions, especially about the future. So one of the considerations about moving any resource around is where are the vaccines? Are they in a factory somewhere? With students, we will say, so should it be elderly? Should it be pregnant people? Should it be doctors and nurses? Should it be? And then you have them that discussion for a while. And then the right answer, I think, is the first people to get the vaccine should be truck drivers. Otherwise, they're going to sit in that warehouse for a really long time. So we need to get the vaccines out to where they can be distributed and decide at that point what can be the grip. So vaccine requires some time to take effect. Depending on where it is, you may have to wait a few days anyway to get it, even if it's in your community. I can imagine the queues going around the block for people to get the vaccine, and that's good and have a wait as well. You can tell the importance of people to people something by the length of the queue. So vaccines would be one. When there's a big lotto jackpot, you see very long queues there, and those, of course, are all much longer than the queue to vote. But that's another situation. That first responders who are able to help all of those other constituencies that you mentioned are generally near the top of everybody's list, but precisely for that utilitarian consideration. If you're elderly, or if you're pregnant, or if you're otherwise sick, for example, or immune suppressed, depending on what your malady is, that even then to go through informed consent process. Is this vaccine going to have side effects? What are going to be the downsides? Is there going to be a risk of anaphylaxis, for example? That sort of thing. We've discovered, by the way, as we hope for the vaccine, that those people who disdain vaccines have been blissfully quiet lately. Because if it works, it's going to save a lot of lives, but it's also not going to save all lives. And so I think we want to do this in as thoughtful way as possible to avoid what we call the swine flu problem that we had, whenever that was, 25, 30 years ago, where they miscalculated. We want to get this right because we have an opportunity to build trust in a system. Trust which I have more trust in it than some of my compatriots, but I'm mindful of the fact that many don't. And so I want to do this in a methodical way that's stepwise. And so as we make these allocation decisions, we have a transparent process, and there's an exercise in deliberative democracy. If you ask most ordinary people who should get the vaccine first, they'll probably won't think of truck drivers, but they might say health professionals, because they understand that the rest of us are not going to get it if those people are not one, immunized, and two, able to share it with the rest of us. And that those exercises are themselves experiments in democracy that we can learn from.
Great, thank you.
I have a follow-up to that, Ken. Your explanation makes a lot of sense to me, but right now there's this tension between getting it quick versus getting it right. And how would you juggle those two decisions? If we get it quick, it might not be exactly right. It might be far from right. How would you, curious to hear your comments about that.
So you imagine you have these two sliders, and as the one goes up, the other goes down, and you're making a trade-off like that all the time. One of the things that you do when you test a vaccine, though, is you want to have a really good, diverse group. You can reduce some of that getting it right skepticism by doing good science. And so I am optimistic that if we actually do a rigorous study quickly and as large a population as possible, then that will help us get it quick and get it right. We might very well fail. I mean, at the end of the day, inaction is the. I learned that I've been reminded of the fact that in Dante's Hell, the hottest circle of hell burns for those who at a time of crisis remain neutral. We've got to do something, and so getting it quick and getting it right are at the limits. You don't want to. If you do it too quickly and it's all wrong, that's no good. If you wait too long and it's right, then a lot of people are going to die in the process. And so we've discovered what our tolerance is for making those kinds of decisions, as Emma says, decisions under uncertainty. What I want to live in is a world in a civil society where citizens have higher health literacy than they do, and they're able to understand that people they trust are making really difficult judgments. And you see, by the way, trust in health workers is very high right now. When you saw what they did in Wuhan and in Britain, and now apparently in New York, where they're actually going out at 7 o'clock and applauding and banging on pots. They know that those people are fallible. They know they're not going to get it Goldilocks right. But they also know that they're giving it their best. And if we can convince them about that in terms of the research mission, then that'll be a great way to try and balance getting it fast and getting it right, I think.
Great, thank you.
Let me go to a little bit of the allocation area again. And vaccinations, the allocation there is interesting. And again, as Emma indicates, the concept is that potentially those that are most vulnerable would get it first. But there's also an aspect of medical utility. It goes now to the immediate allocation of resources. The concept that potentially we're going to find that, as we found in New York City, but in turn can occur in other areas of the country, that you're going to get these spikes where there's going to be huge demand for ventilators, for ICU beds, and a limited number associated with that. I know that you and your center have been instrumental in developing a policy for the Florida Hospital Association, a policy that's probably being looked at by the American Hospital Association as well for the country, in terms of how these tough decisions are made. And if I heard right, it's a little bit different from the vaccination methodologies that Emma was bringing up, where you initially give those to the elderly those scarce resources, vaccinations to the elderly and to, say, women who are pregnant and to the truck drivers, and then you sort of step back from that to the younger. But as I read policy and we talk about concepts of medical utility, concept of need, plus probability of success, which comes into play more in the area of the shortage of a ventilator that you need now, an ICU bed that you need now. Talk to us a little bit about ways to think about policy allocation associated with that, if you would.
Sure, that's a great point. Depending on what's scarce, you might need to move some. The value, for example, of perfect equity or a perfect chance, a perfectly equal chance would suggest that everybody should get a ventilator just in case they've entered a lottery. The problem with that, for instance, or random allocation, is that a lot of people are going to get it and die really quickly anyway, meaning that those who could have benefited will not. If you do first come, first serve, you'll see a very similar problem, namely, one, it privileges people who are able to get to the hospital, which further lenses a disparity in our society. But also, if I'm 114 years old with metastatic pancreatic cancer and I show up first, I'm going to die pretty soon no matter what you do. Whereas somebody who is healthier and just happened to have the coronavirus could have actually been cured and lived for much longer. And so what we try to do, and the document you referred to, Steve, is an attempt that's based on, well, in fact, every hospital in every state in the country is trying to come up with the best and fairest way to do this. And what everyone agrees is lotteries are only good as tiebreakers. And first come, first serve is not good for anything. That we need to have identified likelihood of success and length of survival. And that's a problem we face in hospitals all the time, and sometimes with end-of-life care. But now it applies to everybody who gets sick. And so what we've tried to do is using as objective a measure as possible. In this case, the standard is imperfect but widely used. It's a prognostic score, the sequential organ failure assessment score. It basically says, based on a lot of physiological values, what your bilirubin is, what your kidney function is, that sort of thing, whether or not your organs are going to make it so that you live or not. And if your score is better than mine, then it's rational to give you the ventilator and not me if you only have one. And I argue that philosophers should get the ventilators first, but no one agreed with me. And so that attempt to try and say the value that undergirds this in public health is save as many lives for as long as possible, means that we need to do a better job identifying how you calculate that. And so that was the attempt that we've come up with. We've discovered already in some cities in our country, in Chicago and Detroit, for example, that we have discovered that existing disparities in case of African Americans are grievous, and that a lot more African Americans are dying than other population groups because of those disparities. Depending on where you live, depending on what access you have to education, depending on your diet, depending on the healthcare you've had access to, that might affect the very score that I was talking about as objective. Pardon me. Same thing for our disability community. We've been working with people with disabilities for a long time to try and say, you're right, it's imperfect. But if your society is already biased, let's continue our efforts to improve it and reduce those biases. But maybe if it's systematic, you're not going to fix it during a pandemic. Here, at least, is something based on values that most people share. And two, it's based on evidence. So if the individual biases of doctors and nurses in the intensive care unit won't be the ones making the decision. I mean, if they're looking at it like this and saying, well, I don't know, I like you better than I like her, then you've enabled bias as opposed to reducing it. But Steve, it's a really difficult question, and you've identified why it's so important.
And just to follow up to that, and by the way, I invite my colleagues to follow up as well, the concept of social utility and immediate social utility versus more global social utility. So the concept of the person who's a medical caregiver, the doctor, the emergency room doctor, the nurse, sort of getting back, if you will, back out into the field quickly by being able to give them that ICU bed if they're needed, all things equal. That's immediate social utility. But how about then sort of the more global utility? And without getting the politics of it, if you have a 75-year-old member of the Senate or or a person in the cabinet. Where does a person like that align with this very significant scarcity of resources that we are still seeing?
That's a great question. Yeah, I mean, I think if you ask ordinary people who should get it, a senator or someone else, I don't think you'd want to be a senator. On the other hand, depending on the nature of the crisis, we do have concern for the continuity of operations of our civil society. I think what we've all learned, though, by the way, is that senators are not essential for that. I'd rather give it to a police officer than a member than a politician any day. And I think ordinary people might say something similar. The long-term social utility is not going to save a whole lot of lives now, and that senators are. We don't send you to school to be a senator, but we do send you to school to be a firefighter or a nurse or a police officer, right? And that education itself is an investment by society in our ability to take care of our communities. But the list of different social functions, I think, would be really quite important. We discovered this, as you remember, Steve, during the first debates on organ transplantation. You have a scarce resource, and so who should get it? A health economist, a philosopher, or a great poet? And at that level, I think social utility, I think what we said is every human life is worth pretty much the same at that point. If you're not saving lives, then your great economic theory or your great philosophy or your great poem is nice but inessential. We need to regard all human lives as worth exactly the same thing and try and come up with a fairness algorithm that captures that. It's hard to quantify long or short-term value of a human being.
Thank you. Dr. Dean, Dr. French, any other follow-up questions?
I would ask, you said who shouldn't make these decisions, and I would agree that a philosopher or a health economist or a provider or a patient or a family member should not make these split-second decisions, but someone has to make those. So who do we assign that huge responsibility of making those decisions?
One of the things that the guidelines that Steve referred to make clear is that we do not want individual doctors at the bedside in a busy critical care unit saying yes, no, no, yes, no, yes, no. That's unfair to them. We teach our med students, I think as Professor Ullman has done for years, that economics aside, the patient in front of you is really the most important patient. But if the patient in front of you is really sick and old and going to die anyway, you ought to be thinking about those others. And that's hard for you to do. And therefore, the guidelines universally recommend there be a triage team that might very well include a philosopher or a health economist, people with expertise in critical care medicine and nursing, and so forth. It's been suggested you should at least consider clergy, members of disability communities. Try and make sure that not a bunch of straight white guys making those decisions too. To the extent that we don't do a good job of that normally, makes it seem to me that we have an opportunity now to at least signal that we want to try and get it right this time. And so you need to have people who know about how critical care units work and what it means to practice critical care medicine, so they will help their colleagues in saying, we hear you at bed 4, you're not going to get the ventilator, it's going to bed 7. Move on. And it's a service to, so they're not, the moral distress that they would feel at having to do that themselves would be intolerable. These triage teams won't even know who the patients are. And ideally, they won't know what color they are, or whether they're Medicaid or full pay, or whether they're disabled or abled, that sort of thing. And that, I think, is one of the virtues of it. You try and make it as objective as possible with the goals of maximizing survival and then life years. There are other debates, for example, about, what people get upset about age being discriminating on the basis of age. And I say, I don't think any reasonable person would disagree with the idea that you have a 21-year-old and a 101-year-old, and you have something that will save each of their lives, all things being equal. I think the 21-year-old ought to get that, right? And if I'm 101, I ought to say the same thing. It's the idea of fair innings or life years. Namely, if 101, I've had enough shots on goal. It's time for your chance, right? But that doesn't scale down nicely. If you're 51 and Ullman is 52, that's not going to be a good way to distinguish between. I don't think. That's close, by the way, isn't it?
Emma, do you have any?
No, I had no follow-ups. I think my follow-ups are actually asked already, so.
I have one more question. Well, I have many, many questions, but for sake of time, we have put our caregivers and first responders in a very, if you will, unique situation where we have the significant shortage of PPEs, personal protection equipment, and you brought up, why did this occur in the first place? And that's an appropriate question in terms of supply chain. But also now, given that it is what it is, if I'm a physician, a nurse, a janitor in a healthcare facility, an EMT, a police person, and I'm a single parent and I've got 2 young kids at home, and I am not provided the PPE, the patient protection equipment, is it my duty still to provide care, to come to work? What happens to me and what happens to our system given this kind of situation?
Those are the questions have gotten harder as time has gone on, Steve. So one of the oldest rules in ethics is that ought implies can. Namely, that you can't say that I have a duty unless I can actually carry out my duty. And the presence of children at home, we saw this, we were worried about this during Ebola, during H1N1. And what our colleagues in Canada discovered during SARS, even before that, I've heard a new definition of Canadian. You know what Canadian is? It's an unarmed American with healthcare. That they actually came to each other's rescue. If you know that I've got 2 kids at home, then you're going to say, Ken, let's wait till it gets bad enough. We want you to stay home with your kids, because first of all, if you bring the disease home to them, they're going to end up in our institution, and that's going to make it harder. 2, if you get sick, then there will be life after this, and we want to make sure you're available to take care of patients then. And so if we know you've got family members and others who are vulnerable, let your colleagues step up for you. The Canadians did a beautiful job of that. I think that's one of the ways to be thinking about this, to defang it. There are a lot of people who are behaving, our colleagues at the University of Miami and sister institutions are behaving really quite heroically. They do have families, and they are suiting up every day and walking into critical care units where they're being exposed to this virus. Their children aren't young, they're more mature, they have better experience, and actually all they're asking for is you don't sue them afterward. Although this is the United States of America, and our right to blame people after the fact is well established. But the short answer to your question is, I don't think it's fair to assign that duty to everybody come what may. I think we need the filtering mechanism to say, if you've got kids at home, we want to try and have your back and find others who will do as well, because the next time it might be that I have kids. We do a better job thinking about how we can support each other. And I think that's the beginning of the right answer, namely, let's emulate what the Canadians did during SARS.
Thank you. Michael, any follow-up? I want to be cognizant of Dr. Goodman's time as well.
Let's maybe end on a happy note. So when restrictions are lifted, Ken, what is the first thing you're going to look forward to doing?
You said this was being recorded, did you not? What we've discovered, I think, among other things, is in a very sweet, a wholesome way, is that we interact with each other in ways as mammals that involve. I mean, you remember you used to have problem with people who didn't know about personal space. You know, many of us are from cultures where the greeting is an embrace. And so when I know it's perfectly safe, I intend to go around and hug a bunch of strangers. Thank you.
Thank you. Thank you, Dr. Goodman. Thank you, Dr. Dean. Thank you, Dr. French. This has been really insightful and great conversation, and I know we could go on forever in terms of this. Please be safe, everybody. Take care.
Thank you.
Yeah.
Bye.
Bye.
Thank you.